maybe I can start with asking Dr. Arora. Thank you for your excellent talk, but I'm a little bit confused about what you mean by treat all, because WHO guidelines actually don't treat all. They treat DNA more than 2,000 and ALT abnormal. So treat all is the public health viewpoint where S antigen positive, don't do DNA, don't do ALT, treat everyone. So which place are you at? Are you saying treat S antigen positive everybody, or are you using WHO guidelines?
I showed a slide, I can project it again very clearly. If you are less than 30, if you are immunotolerant, if you are normal ALT, if you have no comorbidities, if there is no family history, that is the only subgroup it doesn't need to treat. Beyond that, there will be 30% gray zone. Either you keep monitoring or you give antiviral therapy. Because guidelines, we are not treating only DNA or ALT. What we are sticking on with guidelines is to one factor. But look at the other social factors. Social stigma, anxiety, neurosis, the risk of development of HCC, the degree of transmission to the family members. Guidelines don't look at that. But in any case, once you have HBsAg, which has got integrated into the genome, especially with perinatal transmission in India, then the risk of HCC will increase after the age of 30 years. Up to 30 years, you can argue. But beyond 30 years, I think if you are HBsAg positive, any ALT, any rise in DNA should be sufficient. Because there is 30% gray zone, which is important.
Thank you. Microphone one. Microphone one.
What are the stopping rules for giving antiviral drugs in chronic hepatitis B?
Yeah, I showed you stopping rules both in E antigen positive and E antigen negative. In E antigen positive, see, all these stopping rules we know and they are important is because as of now, the drugs which we have for treatment of hepatitis B are acting at the fag end of the cycle. You are totally leaving it unattended at the time of entry, at the time of integration to the nucleus, at the time of proliferation. That is the reason we talk of these stopping rules. So if you are HB E antigen positive, and if you have become HB E antigen negative, if you have given ALT is normal, and if you have a consolidation phase of 1 year on antiviral therapy, if on that also you continue to be HB VDNA negative and normal ALT, you can stop it because the durability of this response is to the tune of 70 to 90%. That is HBsAg positive. Coming to HBe antigen negative set, there is a good data published from multiple centers that if you stop the therapy after 2 years of sustained therapy when the patient has a suppressed DNA, normal ALT, then 1/3 of the patient may remain suppressed, 1/3 of the patient will have aggravation of the symptoms, again reactivation of the disease, 1/3 will improve. But that 1/3 aggravation of the symptoms may be troublesome, including fatality. So you have to be absolutely careful in HBe antigen. So far as I am concerned, I think in Indian setup, it's better not to stop HBe antigen related HBV.
Thank you.
Okay,
If I could add,
yes, go on.
can I, just one small comment on that for practicality purposes. My recommendation would be if you're planning to stop therapy on anybody, either you have experience on that or you talk with somebody that has experience. Because as the doctor said, in a lot of cases you have a flare, but you could also have a seroconversion, and it's important to try to distinguish that. So I recommend if you're planning to stop treatment, either if you're not experienced, be sure you're in contact with somebody that's experienced on that.
Okay, we have a lot of people asking, so short answer, short question, short answer.
E antigen, a patient is on long-term treatment. You find that the patient is perfect, DNA negative, but the S quantification is up. My point is there errors in testing methods which can give you a false high S quantification when the patient is really doing well? Or are there variations in S quantification?
Yes, actually, we were talking about that last night. So we, in the US, we don't use surface antigen quantification. So really I think if your S quantification is going up or is stable, the only thing I would do is not remove the treatment for sure. While if the S quantification is showing me that it's going down, you could consider at some point stopping treatment if other parameters show that. The main problem with that is that what do you consider, I mean, when the trend is up or down, that's easy, but the lower limit of detection varies quite a bit in which population you're talking about. So I would be careful with that.
Okay.
So the only thing I would say, if it goes up, I wouldn't stop the treatment, but for the rest.
Thank you.
Microphone one.
Thank you. Dr. Arora and I go back nearly 3/4 of our lives since we were teenagers, so I suppose people will excuse us for this. Dr. Arora, there are, for each of the arguments, I can find a counter. There are many other conditions where virus is present in the body, we don't treat unless it causes problems. Herpes zoster is a case in point. For many other diseases, including those that you and I deal with, hepatitis C, we don't have a quarrel when we don't take host factors such as age, gender, family history, etc., into account. We don't seem to quarrel about that. The challenges are also when we say people should be treated, when WHO says people should be treated, they didn't mean everybody should be treated. Those percentages were supposed to be percent of people eligible. And we are trying to look at it as percent people found infected. Also, as we also discussed a little bit yesterday, there are, in general, the onus on medical profession to treat is much more stringent. Remember, we all accept 5% alpha error but 20% beta error, and that's not for hepatitis B. Times immemorial that has been done. We need to have stronger evidence and less chance of error when we intervene than when we do not intervene. When we treat these people, many of them are going to stop treatment with risk of flare that has been talked about in other contexts. Also remember, their viral loads are much higher. The resistance rates that we know are low are with lower viral loads than what happen in immune tolerant people. So there are many things. For each of your arguments, there would be counter arguments. Thank you.
You want me to comment on each argument?
Depends on the chair.
Short answer.
You see, 1 minute, let me comment. You see, once he has raised this question, if you analyze, Dr. Rakesh, whatever has happened to see the results of 10, 15 years of guidelines, what we have achieved. And there has been good persistent data to show that all those who have been refused treatment based on the flimsy guidelines of HBV DNA 2000 and not 1900, ALT of 40, not 39. What has happened to them? 50% of the patients who had developed HCC, they were refused by guidelines. How do you know unless you start giving treatment that they could have been prevented? So I'm not saying treat all, but I think the guidelines have to be more liberalized.
Start trials to show that
but you don't let this start because the guidelines don't recommend. You never let the trial start. If you would have started it in 1220, we should have answers today.
Sir, trials are not stopped by guidelines. People can always do trials.
Okay, we should start trials. At least you admit that.
I agree.
Prior to that, you didn't even admit that.
Can discuss this offline. I think microphone 3.
Yeah. My question to Professor Jose. So, in your experience, you see any different kinetics of HBsAg after liver transplant? Because I have not to publish, but we find the HBsAg loss and development of anti-HBs antibodies is in fact more seen in post-liver transplant patients, even if they are on immunosuppression. So, your thoughts about this thing?
So, what is the question exactly? So we actually don't do that in the US. We don't even do quantification after transplantation. So I wouldn't be able to answer that, at least from my experience.
Microphone 2.
So my question is for Dr. Arora. When you have low DNA levels and you're deciding about treatment in this group of patients, you know that ALT can be increased by a number of other factors. 30% of our population has fatty liver disease. They will have elevation of ALT. So don't you think that fibrosis is very important when you're trying to treat patients with low DNA, or you should treat all?
Yeah, you see, again, as I said, let's not have a prismatic view of only looking at the DNA. You're looking at the totality of the picture. And this study from Zambia as well as Egypt has shown that in fact patients who were not given treatment for hepatitis B because they had a DNA which had not touched 2000, they had a worse outcome. And it was more cost effective to treat this subgroup of the patient. DNA is one factor. You have so many other factors. You have comorbidities. How do you know they will not contribute? If you have a concomitant NASH, why do you want to wait for it to become fibrotic before you start treating these patients? And with a persistent DNA, there has been shown to have 30% of these patients over a period of time will develop HCC. HBsAg quantitative and E antigen will also contribute to HCC, and you're also integrating the virus into genome. So a single figure of DNA alone will not deter me for not giving therapy.
Thank you. Microphone 3.
Yeah, just one short question. I have a patient with non-cirrhotic Hep C. I started him on Sofos and Decla, but the SVR was not achieved. So according to guidelines, I gave him Sofos, Velpan, Ribavirin. But again, the SVR was not achieved. So what should be my next step?
So you have two options. Either you buy Voxeloprevir, which is available as compassionate use program. The cost is about 1.6 lakhs per box of 28. So you'll end up around 4.5 lakhs. Otherwise, you give him, stop Velpatasvir, add Ribavirin, give him 24 weeks of therapy.
Okay. Thank you, sir.
Last question.
Yeah, my question is to Dr. Jose. For the HBV RNA, the primer sequence which are published, does it have any geographical or ethnic variation, or will it work in India?
That is a great question. I think, if I understand your question correctly, in terms of the virus, it shouldn't matter. So all the sequences that have been looked should be basically applicable to different genotypes. The problem is that the test, that's right, where you're looking at the digital droplet PCR or RT-PCR, the sensitivity varies quite a bit in here. I don't think it's related to the virus per se, but it's definitely related to the technique that you use. So at the end of the day, it's no standardized technique, and that's why we need a bit more of
But the technique is almost same as you do for the HCV RNA PCR methodology?
Well, we don't do digital droplet for HCV RNA, because it's also the part that you're looking, basically, at the part of the genome that you're looking, basically. So it's not exactly the same technique.
With this, I need to thank all the speakers and the audience for an active participation in this session. Thank you, everybody.